I heard Dr. Ailalwadhi in April. He gave a talk at Parkview Community Hospital, and I asked him, and he agreed to come talk to us. Dr. Ailalwadhi is, I find, a very personable person, someone you can go up and talk to. He's very friendly. I'll just read a little bit about his bio, and then we'll get to it. While pursuing his education, Dr. Ailalwadhi was routinely recognized for his academic accomplishments, receiving awards for excellence in the field of biochemistry, physiology, he went upstate to New York for residency and fellowship programs at Roswell Park Cancer Institute at State University of New York at Buffalo. Now I'll just kind of skip and just get to the meat. Many of Dr. Ailalwadhi's research interests are focused on treating multiple myeloma, chronic lymphocytic leukemia, and Waldenstrom's macroglobulinemia, which are all cancers of blood cells. He has been participating in various research projects since 1998 and is the principal investigator on a clinical trial that studies the effects of different medications in treating Waldenstrom's. His extensive research has allowed him to co-author nearly 15 publications and abstracts from noted medical journals and book chapters. In 2007 alone, Dr. Ailalwadhi was invited to 6 different conferences to lecture on his research, visiting such cities as Chicago, Buffalo, Palm Beach, and Boston. So would you please give a warm welcome to Dr. Ailalwadhi.
Thanks a lot, guys. Thanks a lot for having me here. And as Anthony mentioned, back in April when a couple of us were invited from USC to come and talk at a forum, we sort of discussed a lot of things. We talked about multiple myeloma, some of our own research, and some of the things that were going on. And soon after that, Anthony and actually Monica was there, and they had said, well, would you like to come to our patient support group? I said, yeah, sure. I obviously realized that it would happen somewhere in Riverside. I live out in Thousand Oaks, so it's about a 2.5-hour drive. And actually today when I was leaving, my wife said, you know what, it's very good, you're going to a patient support group, etc. That's very nice. But next time maybe we'll come along or something like that, because it's a whole day process. And I've got a 2.5-year-old and a 4-month-old at home. So I know what my wife is more concerned about is that she's going to be dealing with both of them for the whole day by herself. So, but you know what, first of all, thanks a lot for having me here. It's really nice. And I had contacted Anthony a couple of weeks ago and said, you know what, I'm probably, if it's okay, not going to bring any PowerPoint slides or any presentation, because the way I look at it is this is more of a two-way communication. From what we just heard, those of you who were at that particular seminar felt that one of the good things was that you could approach the docs and you could ask them questions. And either that was to revalidate what you were getting and sort of get that sense of confirmation that what you were getting was indeed appropriate, or it was talking about cases that had had very good success so that you derive some hope from it. So if it's okay with you, I'm going to be more than happy just having it open forum for everybody. I'll be more than glad to answer any questions from you guys, and then we'll also talk about some of the stuff I'm doing, some of the stuff where the myeloma field is going as a whole. And just before starting, we discussed a couple of things about clinical trials, and I think that is something we'll talk about as well. So just briefly a little bit about myself. I trained at Roswell Park in Buffalo, like Anthony mentioned, and then I moved to USC about a little more than 4 years ago. And obviously no points for guessing why Buffalo to Los Angeles. But it's been a very, very good stay at USC. It's been a very good experience. I would say that for the first year or so I was here, I was not too sure of how I was going to build up my research career, because at Roswell there was a very protected environment. I had my mentor, I had a whole lab that I used to work with. But coming to a brand new place, setting up right afresh, the thoughts were, how am I going to do this, or what am I going to do, or how do I want focus on my research. So, but right now I think I'm at a stage that there are so many good things happening, both in the field of myeloma, within our research group, that there is a lot to talk about. And I think there is a lot of hope, and there's a lot of innovation that's going on in myeloma field. So, so if it's okay, I'll start a little bit by talking about, we just started talking about clinical trials before we start the meeting formally. So, all of you, either yourselves have this diagnosis or have had family and friends with this diagnosis. I want us to go back to the point, or when a patient is diagnosed, when you yourself or a family member or friend is diagnosed with multiple myeloma. Obviously, this term representing cancer is life-changing. And then your life from there onwards is going to be completely different from what it's been so far. But at the same time, I want us to focus that approximately 10 years ago or so, the average survival of multiple myeloma patients published based on large national and international databases was about 2 to 3 years. So from the time a patient got diagnosed, an average patient would live 2 to 3 years irrespective of what treatment they got. This is around the year 2000. Now, the coded number is 5 to 7 years. Of course, the research lags behind practicalities, but as it was mentioned a few minutes ago, you guys came across patients who've had diagnosis more than 10 years, more than 20 years, and are doing fine, or going on. So all of us who deal with multiple myeloma and take care of patients with multiple myeloma, we have had patients who do live that long and have an excellent quality of life. Because the way I look at it is not just a matter of prolonging life, but also maintaining quality of life. I think that's very, very important. Now, so obviously there's a lot of hope. Newer drugs have come along. The older drugs that we've had, they've been revalidated, and their results are even more promising than what they were several years ago. And more and more research is going on in multiple myeloma, to the extent, if you notice, every year in December, the first weekend of December, is the American Society of Hematology annual meeting. I'm pretty sure a lot of you are probably keeping up with the data that comes out of that meeting. So if you were to just go to the American Society of Hematology website and just search the term multiple myeloma to see how many papers and research projects are presented on multiple myeloma each year, over the past decade, that number has more than tripled. And you can imagine that multiple myeloma is getting so much traction, so much attention, so much importance, not just because we didn't have this disease in the past or this is a new disease, but because we have so much more we can do for the patients who have this diagnosis. And when I see a patient who's newly diagnosed with myeloma, obviously it's at least a 1 hour long discussion that I have with them just to go over the diagnosis with them, the ramifications of it, and it's not an easy discussion, because on the one hand, you're talking to the patient about their new diagnosis of a cancer, but on the other hand, you're not showing them a scan and saying, hey, this is the tumor, you've got metastatic disease, we're treating it. It's something that's in your blood, it's a protein. All of us have these cells, even healthy adults have these cells, but myeloma patients have more of them and produce this protein that's going to work on your bones, that's going to cause kidney problem, that's going to cause your blood count problem. So it's a very detailed discussion. What I recommend is the one advice as a patient that you can give to others is please make sure that at that meeting you have family, you have friends, you have people you trust in, so that everybody can soak in that information. Then the other thing I want to talk about, and I want to mention, is it's always good to ask for a second opinion. It's always good to look for a second opinion. And being a doctor, I don't feel, and I shouldn't feel, that it's hurting my ego that my patient is asking for an opinion. No, I don't think so. If we are to buy a TV, we're going to do a lot of research. If we are to go out and buy a car, we're going to talk to different dealers and look for the best price. This is our life. So it's not a vote of no confidence to your doctor. It's appropriate to look for a second opinion, or even ask your doctor, hey, you know what, is it okay if you put me in touch with somebody I can talk to and maybe discuss other options? So I think that's very, very important. Please keep your minds open from that standpoint. So we just started talking a little bit before the meeting about clinical trials. Importance of clinical trials, importance of participating in clinical trials. So I want us to think that every single drug that is approved by the FDA for use in any ailment, could be as simple as Tylenol or Motrin, everything has gone through clinical trials to establish its safety and what we call its efficacy, which means its effect and its success. So being on a clinical trial does not mean that the patient's a guinea pig or that there are no other options. So the standard life of a drug is that a drug is established in the lab, scientists work on it, make sure that the drug works in the petri dish on cells. The next step is that same drug is tested on animal models to look for how it affects the tumors and how does it cause any side effects or toxicity. Typically, animal models are mouse models and monkey models. Mouse models looking for response, monkey models looking for side effects and response. And once the drug has made its life through animal models, then it comes to humans. Initially in humans, the first stages of clinical trials are looking for side effects, okay? Because as a principle of medicine, when we become doctors and we get trained, the first rule is that we're not going to do any harm. So before giving a patient any benefit, we're going to make sure that we're not harming somebody. So the first phase 1 trials, early phase trials, are to make sure that the drug is safe. There is still about a 5 to 7% quoted rate of success in a phase 1 trial. So phase 1 trial is not just for testing on humans. It's basically, there is a small but sure chance of the drug working and giving some benefit. Once the safe dose has been established, the drug's escalated to what's called a phase 2 trial. The phase 2 trial is everybody with that diagnosis that meets the criteria for that study is given that drug. There's no comparison. You're not comparing two different drugs or standard or non-standard or whatever. A phase 2 study is that drug alone or in combination given to everybody to confirm the safe dose and now to actually start getting data on how effective this drug is. And then when the drug has made it through the phase 2 trial, then it goes to the phase 3 trial where that comparison thing comes, which seems to be the biggest concern in all of our minds. Because when a patient is talked about a trial, they would commonly say, well, I don't want to give the sugar pill. I want to get the drug. I want to get the real thing. So you have to know that the sugar pill thing comes only if there's nothing standard to compare to. Okay, I'm going to spend a couple more minutes on that. When the drug has made it through phase 2 trials, the safety and effect has been established, then the phase 3 trial is to compare the drug or combination of test drugs with whatever is currently standard. If there is no current standard, then the sugar pill concept comes. But if there is a current standard, the test drug or the study drug has to go head to the current standard to prove that it's better. Okay? So that whole idea that a clinical trial is going to give me a sugar pill or an inferior drug is not correct. The drug has made it to a phase 3 trial because there's enough promise that we think it can beat the current standard. Okay? So think of it that way. And let's say the flip of coin gets you the standard treatment, well, at least you're getting the currently best known treatment for your disease. If you get the study drug, then you may actually be getting something better, hopefully. All said and done, there are negative trials. There are studies that show that the study drug was not as good as the comparator, but if we don't test, we won't know. And then after the phase 3, generally, the drugs get approved by FDA, and the phase 4 happens when, after the drug is approved, more and more data is collected on an ongoing fashion about the safety of that drug and the long-term safety side effects. So, so a common thing that happens, and I apologize, I don't remember, I didn't get your name.
Karen.
Karen. One of the things that Karen said was that when she was diagnosed initially, a clinical trial was mentioned, but she was not ready for it. She thought that there was so much overwhelming information that it would be easier to go with whatever would be the standard. And I think I completely understand that, and in a way, I think I agree with that. There is so much information, there is so much going on when you get diagnosed. The last thing you want is a 26-page long consent that, including everything else, will tell you you could potentially die from this drug. So that's the last thing you want to read. That said, I still think that where we are today is based on clinical trials. Where we are today, the success we have achieved today is based on the success of our drugs proven in a clinical trial setting, because you have to study it in a controlled environment. Let's take the example of drugs that are available to us today. Revlimid, thalidomide, Velcade, melphalan, cyclophosphamide, now carfilzomib, and a few others coming down the pipeline, hopefully within the next year or so. All of these drugs were first tested in an early phase setting. Early phase, I know this is a little confusing, so I'll try to explain as I go on. Early phase study meaning study for patients who have already run through the current standard, which is phase 1, phase 2. Phase 1, phase 2, or phase 1 studies. So these drugs showed their effect and safety in patients who had failed everything else. And then slowly and gradually, these drugs would make their way to a newly diagnosed patient. Some of you may have gotten, let's say, Velcade when you initially got diagnosed, or Revlimid when you initially got diagnosed. 10 years ago, you would not have gotten those. But that's because these drugs have made their way to an earlier and earlier setting in the clinics. So right now, for example, the way carfilzomib is approved is, it's approved for, or just got approved 3 weeks ago, for patients who are failing Revlimid and Velcade or are refractory to it. But that said, there are studies that have already been done with carfilzomib in newly diagnosed patients. Very good results. So I think it's important to consider clinical trials at any stage of the disease, at any time during the diagnosis, because if you are informed, if you have faith in your doctor, if your doctor has faith in a study, then you may be getting what the best treatment is and something else, or some improvement on the current best. So it's always good to consider that. Any questions so far, or any thoughts?
When you mentioned the phase 2 studies, you said those where everybody got the study drug.
Phase 2s are generally not comparative studies, generally.
Well, if each of the patients has a diagnosis, if they're not getting standard treatment, is there anything going on with it? What happens if this, not all drugs pass, some of them fail?
Yep.
What happens to these people that are diagnosed in a phase 2 study, it just doesn't work?
Okay, so let me rephrase that and let me try to understand the question. So what you're saying is that since it's not a comparative study, patients are getting, or everybody is getting the same treatment. What if the treatment doesn't work? And everybody has not, in all the patients, the treatment has not worked. Is that? Okay. So the way clinical trials are designed, it's actually gone through tons of checks. So let me tell you what I have to do if I have to write a study. And there are certain studies that I've written at USC that are now being done. So I'm going to not talk about industry because they have their own full machinery that is helping them with the study process. Let me say I have an interesting concept. I want to write a study. So the first thing I'm going to do is I have to write the clinical trial, put in all the details, look for a funding agency, which a lot of times for investigators is a grant or a foundation. MMRF, IMF, they fund a lot of studies, Leukemia Lymphoma Society. Then that protocol goes through at least 2 to 3 different checks by the scientific review committees. So there will be a committee that will look at, is this study sound design or not? Because like I said, everybody's working on that principle, first do no harm. When I'm writing the protocol, I'm working with a statistician. The statistician is building in rules and checks to make sure that we do no harm. So in a phase 2 study, what happens is, let's say, hypothetically, the study is about 50 patients. Okay? A standard phase 2 design will actually say that you first, so although within the study there is no comparison of two drugs, but that study is still based on the historical control. So let's say I have a new drug that I'm working with, which is already safe, phase 1 dose established. I want to do a phase 2 study. In myeloma, it's quite possible that I'm going to go back and say, Velcade would have given me this result in this population, which is already established from previous data. That's my starting point. I'm going to say, I expect my drug to actually have a 10% improvement over Velcade. Based on that, the statistician will calculate that I have to do, let's say, a 50-patient study. And the study will be divided in 2 parts. After the first, let's say, 10, 12, 15 patients, an analysis will be done. And this is standard. All phase 2 studies have this standard design. After the first X number of patients, we stop, take a look. So many of them have to have responded. If they've not, the study stops. But if they have responded, then we go on and enroll the leftover number. And then the full approval happens. But like I said, if you imagine, the checks that are in place are, 1, we've used historical control. We've used an established data published study as our control. We are building on that, and we are hypothesizing that we're going to be doing better. So that has gone into the statistical design. And then there are 2 different phases of enrolling patients. We enroll a small cohort, small group, make sure we see a signal, then we go on. Okay? So there are all these checks. And we do a very, very thorough and close analysis. So within the Cancer Center, there will be a lot of committees, the IRB, the Quality Assurance Committee, that are very, very closely looking at what's happening with studies. So I chair the Quality Assurance Committee at USC. We meet every month, and all the studies that are going on, anything, any violation, any protocol violation, any safety issue that has happened, as a committee, we review all of those each and every month. And then we'll write back to the investigator and say, hey, you know what? Your study has shown this repeated problem time and again. We're going to put it on temporary hold. First, come back and prove to us that what you're doing is right. And then we'll apply. So there's a lot of checks. So we mentioned earlier also, when we were talking, one of the thoughts was, is a patient in a clinical trial given better, closer attention? Although ideally, I would say that every single patient who walks through the door, I'm supposed to take care of them in the exact same way, give them all the same importance, the same care, et cetera, et cetera. There should not be bias in my mind that I'm going to deal with my trial patients different from my non-trial patients. But that's a doctor's perspective. But it's the truth of the matter is that there's a whole set of staff that are dedicated to clinical trials. There's a research nurse, there's a data manager, et cetera. So when a patient goes on a study, their treatment, their data, their day-to-day activities are being looked at more closely by a whole staff of patients, because nobody wants to make a mistake. So every single blood test, every single lab draw, every single visit is documented, just because we have to be able to reproduce that data and then go back and publish it, basically. Bottom line is all of us want to publish our results to make sure that everybody knows about it, that we've actually found something. We want others to know and actually build on that. So yes, a clinical trial patient is actually looked at a little bit more carefully than a non-clinical trial patient. That said, I think that this discussion about whether or not there's a study that's available or appropriate for a patient, that discussion has to happen very, very actively with your doctor. And if you say you're not getting that option available to you, it's very appropriate to look for other places. So I mentioned that clinical trials are very, very important. However much I say that it's a doctor's responsibility to make sure the best treatment gets to the patient, et cetera, but if you come to this side of the aisle or this side of the table, as in from a doctor's perspective, a lot of times we are bound by certain rules that we cannot function in a very open environment. A lot of those rules are, for example, insurances. I'm seeing a patient, and I don't have any studies available for a patient, but so for example, let's take the same example of carfilzomib, because we have something to talk about which got approved 3 weeks ago. So before then, we didn't have a study for carfilzomib at USC, but I had a few patients who I wanted to be on a study, and there was an expanded access program that was going on at a couple of different cancer centers. So I tried getting 3 of my patients pretty much at the same time to this expanded access study. 2 of them went, started treatment, did fine. The third one just couldn't go because insurance didn't have a contract with that cancer center and didn't want the patient moved. And that's where sort of we feel kind of tied down that, I guess I'm not saying that insurances are all bad, but they have their own rules that they're playing with, and we unfortunately can't bend those rules. And I should mention that in California, that seems to be a much bigger issue. I was in New York State, where things were way easier, I should say. But in California, everybody sort of carved out this small piece of the pie. Which cancer center you go to, et cetera, et cetera. I have a young girl, she's 19 years old, has a very aggressive lymphoma. She's a USC student. She has USC insurance. She's getting all her chemotherapy at USC. But when time came for her transplant, she had to go to City of Hope. I just can't, at least as an individual, as a doctor, I can't wrap my brain around it. USC student, USC insurance, chemotherapy at USC for about 4 or 5 months, 19-year-old, very, very anxious and scared with her family, and for transplant has to go to City of Hope. We were able to navigate systems. She's getting her transplant City of Hope. Luckily, all of us, at least in the city, we would know doctors at each of the institutions that we can coordinate things. And she's luckily doing fine right now. Just got her transplant a couple of weeks ago. But I'm just saying the system is just very difficult to understand and can be frustrating. So to bypass those bindings or those issues that a doctor may have, and a doctor may not be able to get you what may ideally be the best for you, I've suggested that there are a few websites, a few places you can go to, and you can do your own research. I'm pretty sure all of you, when Anthony's mentioning that I'm going to be emailing to you all, that obviously tells me that you guys are already up and about, you're up with technology, you're very open to these things. So Heather, I know, was mentioning something about an app that you can go to which will look for clinical trials for you. But a couple of those that I know about, one is trialx.com or trialx.org, I'm not sure which one, in which we go, you will put in your own information, 56-year-old male with newly diagnosed multiple myeloma or relapsed multiple myeloma or anything with, I don't know, uncontrolled diabetes, whatever you want to write, you can check off your own profile. And that will search for every single trial that is open across the country that you are likely to qualify for. And then you can start contacting those places. So that is one option. I guess the sort of the one step back and another way of searching is every single clinical trial that opens in the country has to be registered with the federal government. The federal government collects data on every single clinical trial happening anywhere across the country, whether it is industry-sponsored, cooperative group-sponsored, investigator-initiated, etc. So all of that database is on a website called clinicaltrials.gov. So what I suggest is, and actually that's how I would also research a lot of times, I'm interested, let's say, in a certain drug. And I want to see if anybody is doing anything on that drug in a clinical trial or not. I would go to clinicaltrials.gov, I would put in a search box, I would say, that drug name and multiple myeloma, and it'll tell me everything that is currently open or is ready but not yet started, and whatever is closed. It'll give me the details of all those studies. So I'll suggest actually going to clinicaltrials.gov, putting in some information, let's say, one of the drugs that is going a lot in trials, let's say, is the oral version of Velcade, or the oral proteasome inhibitor. So you could punch in the number, MLN970H, you could put it in there and say multiple myeloma, every single trial that is open across the country with that drug in multiple myeloma will populate. And you can hit that link. It'll tell you what is the basic design of that study. It'll tell you what are the different treatment arms. Is it a phase 1, phase 2, phase 3? What's the comparison? What is being compared to? What's the regimen? How long is the study? How many target accrual, how many patients are targeted to be accrued across the country? Where is the study right now? When was the last time the data was updated? And where all is this study open across the country with contact information of the primary doctor, the research nurse, their emails, their phone numbers, everything will be there. So it's so much more important in today's day and age where we have this technology available. It's so much more important to do that legwork yourself. I think I've trained in a different setting where I can say that most of the cases, the view of medicine is no longer paternalistic. I'm a doctor, but I'm telling you, you can't just completely and 100% just rely on your doctor. I think you'll have to participate in your care more and more. Because actually that participation in your care is becoming easier. You can get that information really, really easily. Any questions so far, or any thoughts?
Apparently, you're obviously pro-clinical trials.
Yes.
Judged by your last 15 minutes.
No points for guessing that.
Now, I mean, number one, I think we all recognize we wouldn't have the meds that we have today without the clinical trials. The question is, do we want to be on a clinical trial, or do we want to get the ones that are already FDA approved?
Excellent point and excellent question. So the way medicine ideally should be practiced is what's called evidence-based medicine. And I'm saying should be practiced because at least I believe in that. And maybe some others may not, so they have a right to have their point of view. There are 3 prongs to the evidence-based medicine. What is the current evidence for something? What is historical data, as in that's been telling us? One very, very important part is what's patient preference? So what I'm saying is not that every single patient all across the country, all the time, has to go on a clinical trial or nothing else. What I'm saying is every time a decision about any treatment is made between you and your doctor, ask the question, is there a clinical trial that I qualify for as well? Because my job as a doctor is not to say, you have to get this treatment. My job as a doctor is to say, in the current setting, this, and this option is available to you. Let's try and sort out through them and figure out which will work best for you at this point. And absolutely that is right, but it's good in a sense that we're talking about multiple myeloma. And the reason is because in multiple myeloma, right now, I don't think anybody can come and say, this is absolutely the drug that is standard and you should have at this point of the disease. We can't say that. We can have 10 experts in this room. I can guarantee that we will most likely have 10 different differences, 10 different opinions. There are certain ways that I like to treat my patients because I believe in that certain thing and I can justify it. Somebody else can come in and say, no, what you're doing is absolutely wrong. This is not the way to treat multiple myeloma. This is the correct way. They will be able to justify their point of view. So I think from a patient standpoint, you need to know what all is currently available. Very often, we talk about multiple myeloma as we've got Velcade, we've got Revlimid, we've got thalidomide, and now we've got carfilzomib. So there are 4 drugs to 4 options. Actually, in multiple myeloma, the math is very, very different. So these 4 drugs will probably give to 16 or 32 or more options because of permutation combinations, what comes first, what comes later, etc. And also there's some emerging data that actually sequencing of drugs may be important in myeloma. What a person gets initially versus what they get later on may actually decide their disease course. I don't think that's established yet, but one of the large clinical trials, which is Velcade, melphalan, and prednisone compared to melphalan and prednisone in newly diagnosed patients who are elderly or transplant ineligible, because you would ideally not get melphalan to a younger patient who can go to a transplant, because melphalan will harm the stem cells and transplant becomes, or can't be done after melphalan. So that study comparing melphalan prednisone to melphalan prednisone Velcade, last year an update was brought up with a 5-year follow-up of that study. So actually at this point I wish I had a slide, but let me try and explain that. Patients were randomized. It was about a 700 patient study. So half of them got melphalan prednisone, half of them got melphalan prednisone Velcade, because the current standard at that time was melphalan prednisone. So the treatment was continued for 1 year, but the patients kept on getting followed on just to keep gathering data on
Same
this.
medication.
So the medication was only for 1 year.
Oh.
Because typically all the Velcade studies, at least in the early setting, tend to give a certain set number of treatment cycles, because we don't want side effects to accumulate, and also that's the way we generally use Velcade. So patients got treatment for 1 year and then off treatment, but data kept on getting collected on those patients. And what we noticed was that the patients who got the Velcade melphalan prednisone versus melphalan prednisone, those patients were living longer without disease, and actually living longer, period. The overall survival was better in the group that got Velcade melphalan prednisone. Okay. That was a 1-year follow-up, then a 2-year follow-up, then a 3-year follow-up, and last year a 5-year follow-up was brought up, which means that patients have, that 700 patient group has been followed for 5 years.
Now, they all still got the melphalan, prednisone, and Velcade, or just melphalan?
Correct, for 1 year.
What happened in year 2, 3, 4?
Exactly. So what happened in year 2, 3, 4 was patients could get any treatment when they progressed. Whatever their doctors thought was appropriate for them. And data was collected that actually half of the patients on the melphalan prednisone arm, when they progressed, got a Velcade-based treatment. So what you would expect is, let's say this group has gotten melphalan prednisone Velcade. This group, which is doing worse and the curve is going down faster, has gotten melphalan prednisone, but half of these patients do get Velcade later on. Do get exposed to Velcade right after they progress. But after 5-year follow-up, we've seen the curves don't match up. It's not that down the road the Velcade was able to pick up the effect in the patients who got melphalan prednisone earlier on. So that is a suggestion that, at least in that 700 patient study, the patients who got Velcade melphalan prednisone up front did better than patients who got melphalan prednisone, and even when Velcade was added on later in their disease course.
So the first year really hit the cancer.
So a thought that the better you hit the cancer up front, it may change the disease biology and may change what's happening down the road. I'm not saying that everybody should get melphalan prednisone Velcade, but I'm just saying that. Yes, so this was an older patient population. I think the average age was 68 or close to that. These are non-transplant eligible patients. But like I said, that is the one study that is telling us that sequencing may make a difference in myeloma. The other data that is very widely being accepted is that, so this is the only study where overall survival benefit has been shown, where it's been shown that patients are actually living longer when they get treatment A versus treatment B. Outside of that, in myeloma world, it's very, very difficult to show that difference, because a patient may go on from drug X to Y to Z to A to B to C, and it's hard to tease out what gave them more benefit. Or if you're seeing a benefit, can you give that benefit, or can you assign that benefit to any one of the drugs? It's very, very difficult. So since we don't have a survival benefit that is proven to be a lot in myeloma world, there is more and more data that has come out that the depth of response may be used as a surrogate of long-term benefit, which means that if a patient is achieving a complete response with treatment, they are more likely to do better than a patient who does not achieve a complete response. So let's try and digest this statement and try to see how that affects our treatment. The way I use this statement is that I have to pick a treatment for my patient that gives him the best chance of achieving a complete response, or as close to that as possible. Does that make sense? So, because we know that whoever has gone to a CR will have the longest disease-free is, the myeloma cell lives inside our bone marrow. Myeloma cells won't grow in a lab. If you put them in a petri dish, they won't grow. They are very, very heavily dependent on the environment of the bone marrow. I'm sorry. Maybe some sort of a diaper emergency or something. So the myeloma cells are very, very heavily and intimately dependent on the environment in the bone marrow. So when we have to grow the myeloma cells in the lab, we actually have to mimic the microenvironment inside the bone marrow. It's called a bilayer membrane, which means we are first creating an environment and then putting in the myeloma cells, and then they grow. So the concept is that if we're targeting just the myeloma cell, it's not going to be enough. So we have to have something that targets the myeloma cell, we have to have something that targets the environment, and we make the whole thing sort of inhospitable for the myeloma to grow. So I think there's very clear data that a combination of drugs is going to work better generally than an individual drug. So taking drugs from different classes is the key to that. And you have response to thalidomide, you have response to Revlimid, but you mentioned that the Revlimid response was shorter.
4 months?
So that tells you that the thalidomide and Revlimid are the same family.
Well,
So
the only difference is an NH2 myeloma.
So that tells you that
I know, but
your myeloma has in some way developed resistance.
I think it's the same type of medication.
Yes.
So that was the point at which my oncologist said, let's hit it with something different.
Completely different, absolutely. And that's, I think, a very good approach. That's the appropriate approach. Because if you failed one drug in a class, a second drug may not give you that much of a benefit. So that's why actually our interest from, let's say, carfilzomib, the way I look at it is, it's a drug in the same family as Velcade. It's going to work. This mechanism works in myeloma. But in my mind, the important thing is, I've had experience with Velcade for about, let's say, 10 years. What is this drug going to do in my patients who are refractory to Velcade, in whom Velcade has stopped working either alone or in combination? So in my mind, that's the most important data I can get out of a new drug. So pomalidomide is coming down the pipeline. It's another drug in the same family as thalidomide and lenalidomide, or thalidomide and Revlimid. Now, in my mind, the important thing is, what is pomalidomide going to do in my patients who are failing or have failed thalidomide and Rev? Because I think that's the importance of that drug today. For my newly diagnosed patients, I can probably say, well, pomalidomide is better than Rev, is better than Thal. So going down the road, I have to get my patients on POM rather than Rev and Thal. But I have still this whole large population of patients that I need to take care of today who are failing those drugs. So I think that result becomes more and more important. What is a new drug going to do in patients who have failed or are failing the currently available treatments? So I think that's important. So when you look at a clinical trial data of a new drug, focusing on what is this drug doing in patients who have failed other treatments or were refractory to them. I think that's one important key. Then, like I said, I started off saying that combinations work better than individual drugs. With that same idea that you're targeting the disease from different angles. 3 years ago, data was presented at the ASH annual meeting, so I think in 2009 probably, that triplets were in some way better than doublets. And one of those combinations is all the steroids. So let's say triplets meaning Velcade, melphalan, prednisone. Velcade, cyclophosphamide, dexamethasone. Velcade, Revlimid, dexamethasone. But 3 drug combinations were working better than 2 drug combinations, one of everything always being steroids.
Because they all work by different mechanisms.
Exactly. And
So they're not fighting each other, they're actually additioning, they're synergistic.
so some of them may be additive, some of them may be synergistic. But the way data kept on emerging was that a triplet was giving us deeper responses than a doublet. The following year, the idea was, are 4 drugs better than 3? But that didn't pan out. So we know that 4 drugs are not better than 3, but 3 are clearly better than 2. So the current strategy I use is that all my patients newly diagnosed, unless there is something prohibitive against a 3-drug combination, will start on a 3-drug combo to try and get them that depth of response as fast as possible and then keep it there for as long as possible. Okay. So some sort of very generalized guiding principles about myeloma care. So any other thoughts, any other questions so far?
You mentioned that sequencing may make a difference in myeloma. I guess I don't understand what you mean by sequence.
Okay, so what drug is used early versus what is used later on? So there's a generalized, or I shouldn't say generalized, but a commonly held view that I've heard from our fellows, our residents, community practitioners. One of the thoughts, and please, by all means, I don't mean to sound that oncologists in the community are doing something wrong. The main idea is there's so much happening in oncology. Multiple myeloma in our lives is the most important cancer diagnosis. But if you were to look at law of averages or just generalized numbers, there are about 20,000 new patients with myeloma diagnosed each year. There are hundreds of thousands of patients diagnosed with other cancers. Okay? Colon, breast, prostate, lung, they are way more common. So it's hard for somebody who's doing the great job and important job of taking care of all kinds of cancer patients to be necessarily that up to date with every single disease on that very day. So one of the thoughts that keeps coming in discussion is, I don't want to use up all my options right now. I want to use a treatment right now that will give me a response. When the disease progresses, I'm going to bring in something different. When the disease progresses, I'm going to bring in something different. I don't want to use up all my ammunition right away. So that was sort of the starting point for this discussion, saying, okay, if we are to use our drugs in a sequence, then what sequence should we use them in? What should be used as the first one, the second one, the third one? So from that study comparing melphalan prednisone to melphalan prednisone Velcade, it seemed that at least in those 700 patients, patients who got Velcade early are continuing to do better than patients who did get Velcade but later on. So that's what is giving us an idea. Again, I don't want to generalize that everybody should get Velcade first, or second, or third, or not first, or whatever. But I'm just saying that some general idea that how we sequence our drugs may make a difference. We still don't know the correct answer, but we're
You need to say
getting
the
there.
order which the drugs are given to the patient during their cycle of chemotherapy.
During their lifetime, no, not during that cycle of chemotherapy, during their lifetime. So right now, hypothetically, patient is on Revlimid. Down the road, they start on Velcade. As against a patient who was first started on Velcade when they progressed were given Revlimid down the road. So we don't know if both the patients are going to do the same or not. So the reason this sort of discussion is coming about is because in colon cancer, for example, most common cancer out there, in colon cancer, we know that there are about 6 or 7 main drugs. As long as a patient gets exposed to these 7 drugs throughout their lifetime, they do fine. I'm sorry, I shouldn't say they do fine. Patients will derive enough benefit out of these drugs as long as they get exposed to all these drugs. I think in myeloma it's a little bit different. If we have 4 drugs, it doesn't mean that as long as a patient X and patient Y get all the 4 drugs throughout their lifetime, they're going to do the same. I think it will depend on what did the patients get first, When they progressed, what did they get second? What did they get third? What did they get fourth? So that sequencing may be important. And also because myeloma is a very, very heterogeneous disease. You guys would realize not two patients with the same disease do the same thing with the same drug.
Well, everybody's myeloma is different.
Exactly, exactly. More and more studies are getting to that point that can we actually determine at the time of diagnosis what a patient is more likely to benefit from? I think there is some data in that region already. Like for example, if a patient has kidney dysfunction to start with, kidney dysfunction is a common problem in myeloma. About 20% patients right at the time of diagnosis will have kidney problems. So if kidney problems are there and they are myeloma related, we know that the patient should get a Velcade-based regimen. For the reason, because there is published data showing that the Velcade family, or the Velcade family, because now there are two drugs, Velcade and carfilzomib in that family may help more in patients who have kidney problems. Now that data is not proven for carfilzomib, but those studies are ongoing. Similarly, when patients get diagnosed, we check their bone marrow for certain mutations. We know that majority of myeloma will have some mutations. We don't know the importance of all of them, but myeloma cells will have certain mutations. And we know that if the patients have a couple certain mutations, let's say Velcade may be a better option. Or if a patient has a certain mutation, then they shouldn't even waste their time on a transplant because the transplant's not going to work. And they're just going to break through the transplant, so why expose to the transplant if we know it's not going to work? So
We're going to do that until 15. Okay.
go ahead.
You had mentioned earlier about not giving melphalan to transplant-eligible patients at induction, I'm assuming.
That is basically the low-dose melphalan that is given as a part of induction treatment, not the high-dose melphalan that is given for conditioning for a transplant.
So it won't affect subsequent transplants, what you've had at transplant?
No. Having one transplant doesn't affect subsequent transplants because the melphalan is toxic to the stem cells. But remember, before the transplant, your stem cells were collected, then you were given melphalan, and then the stem cells were put back. So now you have this healthy pool of stem cells that are doing their job. But I should mention that in myeloma, the thought process is going away and away from multiple transplants. Because there is a lot of controversy, what does even the first transplant do? Or do we need transplant for anybody? So I trained in a setup in Buffalo where it was a very, very anti-transplant myeloma school of thought. But I think I have a much more sort of moderate sort of view that not everybody should be transplanted, but at the same time, it's not that no one should be transplanted. It's got to be a pick and choose, which I think will depend on a lot of criteria. And at the time transplants being discussed, it's important for a patient to know that transplant for myeloma is one more option, is an option. A lot of times patients may have the misconception or may have this thought that the myeloma is going to be cured. Unfortunately, that doesn't happen with transplant, or with anything for that matter. It doesn't get cured, it comes back. Plus, I guess, like I said, there is a full controversy about who should get a transplant, who should not, whether we should even use a transplant or not. And the reason that controversy is going on is because we know that the way we transplant has not changed in years. 1995 was when transplant became commonly used. We're going to go on. Go ahead.
So in your perspective, like when patients have a stem cell transplant, what's the percentage or the number that you've seen that have relapsed? So meaning they have to go to full chemo after the transplant as opposed to the maintenance dose?
So as of right now, it is actually, I shouldn't say 100%, but close to 100%. That in every patient it will come back sooner or later. What's happening with maintenance is that relapse is getting pushed back a longer period of time.
So it's the average.
Depends on a lot of different factors. Depends on what was the state of disease control going into the transplant, what was the response to the induction treatment, what's the response after the transplant, as in complete or partial or whatever. How long after the transplant the disease has not come back. A lot of these factors will decide that when it will relapse. But I can tell you that at least right now, the belief and the data we have is it will always relapse. The duration will be different in individuals, but myeloma will come back. And I said close to 100%, not 100%, just because we know that sometimes patients may be transplanted or given treatment when they've just gone from smoldering to active. And in those very small proportion of patients, there may be selected cases in whom that treatment and transplant was enough just to put them back into that dormant state forever and ever. So that's why we say that myeloma as of today, to the best of our knowledge, is not curable.
I just have a question. When we were at the conference, what is the difference between remission and complete recovery? Some people said one, some said the other. I thought they were sort of the same.
So remission and response are very interchangeable terms. I'm assuming you're saying complete remission or complete response, right?
Yeah.
Remission and response.
Recovery?
So remission and
There's
response.
a hierarchy of terms that they presented, and they threw it out. And it's like a layer of what they say response was.
Yes. So there is in myeloma there is a degree of response. Okay. And everything goes by the M spike. That's very important to understand. The M protein, the M spike, that is the key. Not the immunoglobulin level, not the total protein, not anything else. The key is M protein, monoclonal protein, what we pick up on SPEP or UPEP. Okay? That M protein number, if that decreases by 50%, then that is a response, M response. So let's say somebody started with an M protein of 5 grams. That's their starting number. The moment that M protein comes down to 2.5 grams or below, that's response. If it stays above 50%, if it stays above 2.5 in that case, then it's called stable disease. If it actually goes beyond the 5 where we started, then that's progression of disease. So our starting point, if the M protein is higher than that, then that's progression. If that's lesser than the starting point, but not yet at the 50% mark, then that is stable disease. The moment it goes below the 50% mark, it's a response, but a partial response. And at the point that the M protein goes undetectable, that's a complete response.
So that's a complete response, not
Complete. Well, the remission is, like I said, interchangeably used with response.
okay.
But there's nothing, but it's a response, because we're looking at how you have responded to a certain treatment.
Okay.
So complete response meaning the M spike is gone and undetectable. That's a complete response. So a partial response, if it has decreased more than 50% but is still detectable at any amount, it's a partial response. And then there are things called VGPR, or very good partial responses. Stringent CR or SCR, those are certain nuances. But the basics to keep in mind are, if the M spike's gone up, progression. If it's gone down, but not hit the 50% mark, then it's stable disease. If it has gone below the 50% mark, but is detectable at any amount, then it's a partial response. And if it is completely undetectable, then it's a complete response. Those are the very basics. There are certain nuances.
You talk I know that myeloma is treatable but not curable. The thrust of your research is anybody working to try to cure it rather than just hold it, hold its course.
Yes, and that's why these thoughts about that we are reaching the point that the patients are living longer. So obviously we're doing something right. There's a lot of research that is going into non-traditional chemotherapies, drugs that can target the myeloma from different ways, different pathways, different clinical pathways. The idea is, if we can hit that one target that is driving the myeloma, we may be able to cure it. The flip side is, unfortunately, there is no one target. So far in our cancer world, there's just about one disease, or two diseases actually I would say, both of them leukemias, in which we know what is the driving force, what is the single target. And drugs have been designed for that target, and those leukemias can be cured. But apart from that, the cells are so heterogeneous, and there are millions and millions of things that are going in those interactions. And that's why a lot of the drugs don't become that successful. So one of the main group of drugs that was brought up last year at the American Society of Hematology meeting was a group of drugs called HDAC inhibitors, histone deacetylase inhibitors, HDAC inhibitors. There's a lot of data that came out of ASH on those, but a survey was done after the ASH meeting. The majority of the clinicians said, you know what, it's a very lukewarm sort of data. And the reason it was considered lukewarm was because it seems that in myeloma cells, by itself, those drugs don't work. Because if you're hitting one target, the cancer cells are smart. They can bypass that pathway and learn to live a certain different way. Again, going back to your example, your myeloma cells became smarter and they bypass the effect of immunomodulatory drugs. And hopefully the proteasome inhibitors are relatively work on that. So cancer cells are smart, they can bypass things.
You know that in a lot of the sections, ovarian, breast, will
Promising and hopefully will be here within the next several months to maybe a year or so. One is pomalidomide, which is the newer drug in the family of Revlimid. One is a drug called elotuzumab. Elotuzumab is an antibody, E-L-O-T-U-Z.
Here's one that nobody can pronounce.
Well, actually, for some reason, for example, the company that makes carfilzomib, they came up with a name which is hard to stick in our minds because all of us are used to saying carfilzomib. We just can't, at least I can't remember the brand name of the drug, but you're right. Some of these names, who knows how they come up with that. But elotuzumab is another drug which is very promising, which actually by itself doesn't seem to do that much, but in combination is very good. So more and more studies are going on with that. Plus it's an antibody, so it has very minimal side effects. But like I said, in combination is the key for that drug, not generally by itself.
We're definitely getting more combinations, more and more.
They will, in myeloma, I think we're more and more getting to the point that we know there will not be that one drug because there is no one mechanism driving the disease. So there's got to be a combination. But like you were mentioning, and going back to the idea that myeloma is very, very heterogeneous. And a couple of you, or whoever were at that forum in April, where also I spoke and discussed a few things. One of the research focuses that I've had is, well, I trained in Buffalo. The population mix was very, very different. Came to Southern California, and suddenly we had this very, very, very different population we were treating. And so my work is both at the Cancer Center at USC, which is the Norris Cancer Center, and at the Los Angeles County Hospital. So we cover both the hospitals, right across the street, very, very different populations. So at the county, we have such a large body of patients, a lot of them Hispanics, a lot of them who may actually come to the healthcare system very late in the disease or when they really, really need to come to the hospital. Because quite a few of them may be undocumented, so they don't want to come into the limelight or the system before they really have to. So I started noticing that, as against what I had learned in Buffalo and what I was practicing in Buffalo, we talk about myeloma as most commonly patients have IgG disease, then IgA disease, and about 7 or 8% have something called light chain disease. light chain myeloma. But I started noticing that in our patients, a much larger number had this light chain disease. And also that we had a much younger population. So we compared so I sort of had a database from Roswell Park in Buffalo for about, let's say 200 myeloma patients, approximately there. So I put together about 150 patient data that were active right now in our system at that time. We compared, we noticed that obviously we had way many more Hispanics in Los Angeles, but our patients were significantly younger, and up to 33%, I think, 32 to 34% had light chain myeloma. Now that's unheard of. Light chain myeloma is not that common. So the next step I did was comparing there's a national registry called the SEER database, which is every single patient diagnosed with cancer, any cancer gets registered in that database, obviously anonymously. So we looked at the SEER database to compare ethnicities. The SEER database doesn't have the clinical data, it doesn't say what kind of myeloma, et cetera. But we compared and we noticed, historically we've known that patients, African Americans who have myeloma, get diagnosed at a younger age. It's more common in African Americans, but African Americans actually live a little bit longer. It suggested that their myeloma may be relatively more indolent or less aggressive. That much we knew from research so far. So we looked at the SEER database because obviously I see a lot of Hispanic patients, and Hispanic patient research was not there. And also I think we have a fair number of Asian patients whose research was not there. So we compared the SEER database, which is about 38,000, 39,000 patients, close to 40,000 patients in that database. And it came out that, yes, African Americans were living longer than Caucasians, but Asians were actually doing the best. Hispanics were actually doing the worst. And there was a significant difference in the survival of these patients.
Were they being diagnosed later?
So Hispanics were actually diagnosed earlier, on average 5 or 6 years younger, around 5.5 years younger than the reference which we took as whites was the reference, because that's what was the largest group. So going back to our understanding of myeloma, we know that typically ethnic populations or multi-ethnic populations have not been represented in clinical trials. And clinical trials are typically majority Caucasian populations. So obviously this sort of research has a lot of implications, as in why are there survival differences? Could it be that the disease biology is different and driven by ethnicity? Because as we were saying that no two myeloma patients are alike, so obviously this is another thing going that actually I can generalize, and these are generalizations because everybody is going to be different, but I can generalize and say, if everything else same, if a Hispanic patient and an Asian patient walk into the clinic at the same time with everything else the same, ages, stage of disease, every comorbidity, et cetera, the Asian patient is going to be living about 2 years longer than the Hispanic patient, right from their time of diagnosis. So that's sort of the thing. The next step in that research was, so this sort of data, this sort of research is out there, published. Our paper got published earlier this year. But what my next step was, okay, I don't want to leave it at that. We've uncovered a difference. Why are these differences? So right now we're going on 3 different approaches to come up with that answer. One is, could it be that the disease biology is different? So we've taken some archived samples. We're going to be running some molecular tests, some mutations, some genetic tests to see if the myeloma of patients from different ethnic populations is different. That's one step. The other one, I'm actually doing a study right now in which every patient, myeloma patient who comes to the clinics, they get a questionnaire. It's about a 4.5-page questionnaire, which looks at their barriers to access to healthcare. How far do they live? Do they have to drive, take a bus? Who takes care of kids at home? Could there be reasons that a patient cannot access healthcare? What's their family history? Do they have a lot of myeloma in their family? Or how is their relationship with their doctors? We know that in certain cancers it's been proven that if a doctor doesn't have, if a patient doesn't have a good relationship with their doctor, they're less likely to be compliant with their treatment. So about a 4.5, 5-page questionnaire that's asking that question from all the myeloma patients, and we're taking the next step and beyond our hospital, we're going to the IRB and getting permission, we can actually send out the questionnaire to communities and say, hey, if you're a patient with myeloma, please fill out the questionnaire and send it back.
Did they look at the subdivisions of Asians? Because Asians abroad.
Yes, yes. And the same problem is also with Hispanics. Hispanics is a very big, broad category. But I'll come to that in a second. You had a question.
I was just wondering if you're looking at diet and supplements and things like
Yeah,
that.
diet.
Yes. So a part of the questionnaire is about body mass index, height and weight, because there is a suggestion also in literature that weight, body mass index specifically, can be independently associated with the risk of myeloma. But again, like I said, just a suggestion, association, it's not to the point like in women's cancers where we know that obesity is going to be the sole cause of certain cancers. In myeloma, we're not at that point. So now so we're not looking at this is Southern California. If I was to ask a questionnaire about supplements or diet, etc., that questionnaire itself would be pages long, because I can tell you patients come to the clinic, and some of them have this long a list of what supplements that they take. And generally, I have a very, very open policy, and I say, okay, I'm not going to say no to your supplements as long as you show them to me and let me read the bottles and try and figure out if some ingredient I know will be harmful. And I'll ask you not to do that. So I'll separate patients' supplements into 3 categories. This category, please do not take because there is proven data that something can happen. This category, sure, go ahead, take it, no problem.
Don't take fish oil, but do take it.
And the third category would be, I have absolutely no idea about what these, because there is no data out there. So let's try and avoid at the time of your treatment, and later on we can go back to it. So coming back to that question about Asians and Hispanics, because those are very, very heterogeneous groups. So in the SEER database, there's a very, very detailed algorithm of how the patient gets put into that category of Asian or Hispanic. And there is another category of Pacific Islander, Asian Pacific Islanders together with Native Americans. But Native American representation is so small, just a few hundred patients, that we couldn't do any statistical analysis. There's just about a few hundred cases of myeloma in the database out of 40,000. So there's a very detailed algorithm of how patients get lumped into these categories of white, African American, Asian, or Hispanic. And those are actually pretty established algorithms that are followed, and multiple researchers have used that. So not going into the details again because my statisticians would know way more because they work with the database, but there's an algorithm that's followed. Nationally, the same algorithm is followed. So we're giving out that questionnaire to patients, and also the next step will be we'll be sending it out to the community and saying, hey, if you've got myeloma, if it's okay with you, please take out a few minutes, read through this consent, which is about 2 or 3 pages long, explain what we're doing, and if you agree with that, fill out the questionnaire. There's a self-addressed envelope, drop it in the mail, we'll aggregate the data. And the third step is through the Medicare, there's a way that we can get healthcare utilization data. Could it be that, let's say in this case, Hispanics don't have the same access to healthcare that, let's say, their Caucasian or Asian counterparts have. So Medicare data can be accessed, so we're planning to do that also. So again, going back to the same point that it's a very, very heterogeneous disease. And there are so many influences that we don't yet understand. But I think it's getting to the point that we're getting more and more data on that.
There's an interesting point that's been brought up in the attitude of an oncologist towards his patient. Am I going to hit him with every damn drug I've got? Or am I going to control the cancer and allow him to have a quality of life? Which is an interesting point, because my father, who died of prostate cancer, said quality of life is probably more important than anything else. The argument is that the University of Arkansas is well known for hitting its patients with every damn drug available, until the comments of a lot of oncologists is, they run out of drugs, and they don't have anything else to hit them with. Is this a philosophy that actually shows works, or
So it's very good you're bringing this up because, again, I'll go back to the fact that as many clinicians, so many opinions. Yes, Arkansas is the notorious example that's thrown out there all the time because their total therapy 1, total therapy 2, total therapy 3, etc. These large alphabet soup combinations that we don't remember, in some cases work, in some cases don't. There's actually one study that was designed to see if that regimen was used out in the community, how would it work, and what would happen.
Except people like Morsheider died, another one died,
Exactly.
and all those who went to Arkansas.
Because unfortunately, that study could not accrue patients because it was such an involved treatment that patients just didn't want it out in the community because it was just too involved. And the reason, and there's another example we have already in cancer therapy in CLL, chronic lymphoid leukemia, where one regimen which is considered in a lot of ways the current standard, it was developed at MD Anderson, and the phase 2 studies were very, very promising. But when that same regimen went to the phase 3, comparing to the then current standard, it still came out the winner. That regimen is still the current standard because it came out the winner as compared to the then standard. But the results of the phase 2 to the phase 3 were way different. The response rates were much, much smaller. So the ideal way of proving that philosophy would be if that regimen, which is lots and lots and lots of drugs in a certain regimen, are compared head to head with, let's say, a less intense regimen. And if in that matchup, this involved and more extensive treatment comes back the winner, sure, then I would say select your patients right and strictly. And if yes, you can select out the patient who's likely to tolerate that treatment, go ahead and give to them because there is benefit to that. So I think that sort of a discussion has to come back to the patient. That is where the patient's ideas have to be importantly considered. So like you mentioned, your father's thoughts were, I need to maintain my quality of life. I have examples in my mind who patients would say, you know what, if I can live longer by 2 months, I really don't care if I'm in the hospital during those 2 months, I want to live longer. And I really don't care what's going on others. Now, again, difficult concept to think about or understand, but some individuals may have that thought. So I think that discussion has to happen, that goals of therapy discussion has to happen with the patient, not just once, multiple times. As a community, we oncologists are the culprits in bringing up that sort of discussion way later in life. Like I said, I'll admit that we are the ones who do that wrong. But I think that goal of therapy discussion has to happen at multiple points during a patient's lifetime in their diagnosis and say, whatever is your goal of therapy, I gotta make sure that I stick with that goal. Because if I take the example of something, let's say somebody has a localized breast cancer. I can tell them, I don't want to misquote because I don't deal with that disease anymore, but I can tell them most likely that, okay, you get surgery, you get radiation, you get chemotherapy, and this is your chance to cure. So you have side effects, deal with them, you've got to get this treatment, because I can guarantee this much percent cure. In myeloma, I can't do that, unfortunately. So that's why I have to have that discussion with the patient and say, I'm not going to be able to cure you. I'm going to be able to put your disease in remission, get you a good quality of response. My job is to pick up a regimen that is most likely going to give you that benefit, but also maintain your quality of life. And that's what I'm doing when I'm searching for those regimens and I'm thinking, what else can I do?
Good balance.
Good balance. But that balance is driven, in my case at least, by my patients. If a patient says, give me that quality of life, let me stay at home, I'll say, okay, your goals are different, we'll cater to that. Versus the patient will say, I don't care about coming to the hospital as frequently as I have to, I've got an incurable cancer. Give me whatever best you have. just because I need to get to that response. I need to get my disease into a better remission. So I think that goals of treatment discussion has to happen, and I would encourage you guys to actually, if your doctor's not asked for your goals, make your goals known to them. Tell them that this is what you are expecting out of that. Okay? Because we're in a time that we're spending so much time, for example, like I said, buying a car. We're telling a car salesman, this is what I want. This is the price, this is the car, this is the features. If doctors can figure out Angie's list, I feel a little bit against that sort of a consumerism sort of a thought. I'm not at that extreme, but I still think this is your life. You have to have that discussion. You have to involve your family and friends who care for you. Because if you see a doctor, that doctor has a paper chart to look at. They don't know you as a person. I may not know what your goals are or what your goals are, but I have to take them into account to come up with a treatment. Because this is a disease in which one size will not fit all. It has to be different.
Do you have any in your research data that reflects exposures that are responsible for multiple myeloma?
So far, the data suggests that it's first of all, there's nothing concrete. There's nothing that has said that so-and-so thing causes multiple myeloma. We don't know. There is some indication with certain agricultural chemicals. There is a small bit of indication with certain kinds of organic chemicals like petroleum products, etc.
VOCs, myself, construction, new homes, a lot of VOCs.
So there is suggestion, but it's important to understand that concept that there is association, there is not causality. Which means that...
Questionable too. I worked 40 years in the oil refining business as an organic chemist, and we all know that benzene officially causes leukemia, but all the organic and the aromatics could very possibly cause leukemia, lymphoma,
Absolutely.
myeloma.
Absolutely. So right now we are at a point that we know there are associations.
There's got to be some environmental factor outside of genetics.
There has to be, but we don't know what that trigger is. And actually, it's good you're bringing that up because I think the research is to the point that we're trying to understand it. Because there was a large study that happened for about 700 or 800 patients of Iemmsg, in which patients were enrolled on the study and parts of their bone marrow were taken centrally to look at, this was done by SWOG, which is one of the cooperative groups, to see if we can try and figure out what triggers that conversion to myeloma from Iemmsg. And at least a couple of genes have come out of that, suggesting that if patients have this gene overexpressed, they are more likely to become myeloma as compared to not. And the good thing is that there's actually an antibody targeted against that gene, which is being now tested in clinical trials to see, well, this is a relatively harmless drug. Can we give it to our Iemmsg patients and prevent them from going into myeloma? So that sort of thing is happening.
That's relatively new.
That's relatively new. That's not yet, I would say, ready for use, but that sort of concept is being worked on.
I think since most of us have read every darn thing on the web regarding myeloma, you know, these are all new factors.
Yeah. So these factors have to be considered. So that's why, for example, I mentioned to you the ethnicity. There is so these researches have to be understood in a way that I mentioned that everything else equal, a Hispanic patient is likely to live 2 years less than an Asian patient with myeloma from the time of diagnosis. But I don't think we understand the factors that lead to that. And so that's why it's very easy to jump to a conclusion. Right now, the environmental exposures, there are associations, but there's no causality. We don't know what caused it. We know that this population is more likely to have the diagnosis. We don't know why.
And do we have any idea why certain number of people, okay, the average age is say 64. Do we have any idea why many of the people that are 40s, and even some in the 30s, get myeloma, which is a rarity. And yet they do it.
And the other important thing there is also that the younger patients tend to have a more aggressive course. So that is where the disease biology is different. The average age of diagnosis is 68 years. But we have patients who are 30 years old. The youngest patient I've had was 29-year-old. And that disease course is way different than a 72-year-old diagnosed with myeloma. That disease course tends to be way more aggressive. So obviously something is happening in the disease biology that we don't understand yet.
But
There's
is it
work
more
that's going on.
controlled?
No, it's not more controlled, but it tends to have a more aggressive course.
Okay.
It tends to have, so an older patient tends to have a more standard myeloma course that we know about. A younger population, a younger patient tends to have a much more aggressive course, less likely to respond to treatments, more likely to just break through things that we do.
Is there any speculation on why that is?
We don't have any understanding of that right now, I should say. Nothing that's readily concrete and finalized. But for sure, and genetic studies are going on, comparing the myeloma cells of the younger population with an older population and seeing how are they different. So those studies are going on, but it's also because these studies require so much time, obviously, but also a lot of money. But those techniques which can help us study these things are becoming cheaper with time. So I think we'll get there, we're not there yet. Those differences will come up significantly.
This is kind of a personal question. My husband has relapsed several times, but right now we're on the three drugs, Velcade, Dex, and Cytoxin, and I don't know where it comes from. You know, I know the Revlimid group and the Velcade group, but where does Cytoxin come from?
So I didn't want to specifically endorse or talk about any specific regimen, but I think I can at least say that that's actually one of my favorite regimens I use for my patients. Cytoxin is the same group of drug as melphalan. It's the same family as melphalan. Okay? These are both a group of drugs called, or class of drugs called alkylators, or alkylating agents. But Cytoxin doesn't have that effect on stem cells that melphalan has.
Oh, it does?
So it does not. And actually, to the extent that we frequently use high doses of Cytoxin to mobilize and collect stem cells, because the stem cell yield seems to be better when high dose of Cytoxin is given to the patients. So what happens is, a lot of times before transplant, we'll admit the patient to the hospital for one night, give them 4 large doses of Cytoxin over a 2-day period or a 24-hour period. And when the counts plummet, the patients get mucogen or growth factor. When their counts come out after that, the stem cell population is preferably increased. So the stem cell collection becomes easier and better. So Cytoxin is the same group of drugs as melphalan. So the same class, but different side effect profile. So the reason this regimen, I really, really like this regimen, is because this is probably, in the literature so far, this is the second most effective regimen we have. There's got to be a reason why I prefer a second most effective as against the best most effective. The most effective published data right now is for Velcade Dex. That combination, every single person who went on the studies for Velcade Dex, and this is a regimen that Mayo Clinic has developed and is working on a lot. The VRD regimen, or RVD, however you may say, every single patient who's gone on to that has achieved some response. When we were discussing degrees of responses, we said partial responses when the H5 goes down by at least 50%. So 100% patients who went on VRD or RVD in the studies had at least a 50% reduction in their Iemmsg. And about 40% had a complete response. Now this was a phase 2 study, so no comparison of standard versus non-standard, and we know phase 2 to phase 3 results get a little diluted, but still 40% CR is really, really good. Now this regimen, which is the Velcade Cytoxan Dex, or the other acronym for this is CyBorD, Cytoxan Bortezomib Dexamethasone, so CyBorD. This regimen has about a 90% overall response rate as compared to 100% of VRD. And it has about a 33 to 35% CR rate as compared to 40%. So very close. Not exactly the same, but very close. And this is a regimen in which weekly Velcade has been studied and proven to be as effective as twice a week Velcade. So it's a very convenient regimen, just like PRD. Velcade is given once a week, Cytoxan is given once a week, Dex is given once a week. Patients get it once a week for 4 weeks on, 1 week off, 5-week cycle. So side effect profile is very, very good, as a much better tolerated regimen. Of course, when I say these response rates, these are for newly diagnosed patients. When the same regimen is used in patients who have relapsed, the response rates go down, but still, like I said, easily tolerated regimens that are convenient and have good responses. Now, I probably have some personal reasons that I would say that I don't use VRD that much. That's because another focus of my research on healthcare economics and cost effectiveness. And the way I look at it is, if I have a regimen that is giving me almost the same response, I have a significant cost because I deal with a county population in which resources are limited strained. I would rather use that regimen. But like I said, I'll admit that even at Norris, even at the cancer center, patients with insurances, etc., I tend to favor CyBorD more than VRD if I was to compare.
Is this Cytoxan cheaper? Obviously,
It's a generic drug. It's a few dollars. Revlimid is a few $1,000s.
Revlimid's $8,400 for 1 month.
So we've actually, this year at the American Study Hematology meeting, we've sent in an abstract last week addressing some of the cost effectiveness issues. Again, I think that's a focus that we've not yet had. But I think those things have to be considered if globally we have to survive.
Last month, we understood that 3 weeks on and 1 week off, and so when you say a 5-week cycle, it kind of threw me.
Okay, so the 3 weeks on, sorry, the 3-week cycle and 5-week cycle have both been studied for this regimen. I'm sorry I didn't want to complicate it, but I should address that. Originally, Velcade has been known to be used as 1, 4, 8, 11. Okay, 2 weeks on, 1 week off. Day 1, day 4, day 8, day 11. That's how it's FDA approved. And we know that some variations of Velcade have happened, which is once a week, can also be given. The once a week efficacy or once a week effect of Velcade has been panned out or has been studied in these combination regimens only. If somebody's getting just Velcade Dex, then once a week won't cut it because it's not enough. But if somebody's getting these triplets, then once a week can be used. One of the regimens is CyBorD, where it's been proven in a head-to-head study. Half the patients got the 3-week regimen, half the patients got the 1-week regimen, or the 5-week regimen. So twice a week Velcade 3 weeks, once a week Velcade 5 weeks, half and half, and the results were exactly the same. The 5-week regimen had better side effect profile, was tolerated better. So that was the main difference that came out of it. So from an effect standpoint, the CyBorD 3-week versus 5-week has exactly the same effect on responses, but the 5-week is tolerated better.
Okay.
So the way we look at it is, if a treatment is tolerated better, I'll be able to keep my patient on it longer and get a better benefit out of it. Very, very frequently in myeloma world, we do the mistake, or again, as a doctor community, as a physician community, I would say we do the mistake, is going back to, let's say, colon cancer example. More common, we're more used to treating it, or at least as a community we're more used to. I'm not, because I don't treat patients with solid tumors, but if a patient has metastatic cancer, metastatic lung cancer, metastatic colon cancer, metastatic breast cancer, metastatic prostate cancer, I'm treating them. If a side effect happens, I'll say, if you're responding, I'm going to manage your side effect so that I can keep you on treatment. Unfortunately, in the myeloma world, we don't do that strictly. Or you've got neuropathy, Velcade's off. Or you've got a clot, Revlimid's off. You've got neuropathy, thalidomid's off. No, that's not right. If the drug is working, I have to manage the clot and keep Revlimid. I have to manage the neuropathy and keep Velcade. I have to manage the neuropathy and keep thalidomide. That's my responsibility. So if the response is happening, I cannot sacrifice any of these drugs. Because the question is not which one is better. Every single myeloma patient has to get the benefit of each of these drugs because all of them work. It's impossible for somebody to stand up and say, Velcade's better than Revlimid, or Revlimid's better than Velcade, or anything like that. Because for a patient at a certain point of time, Velcade might be the better choice than Revlimid. So in your case, Revlimid stopped working, Velcade was a better choice. But that doesn't mean that Velcade's a better drug. For you, at that point of time, Velcade's the better choice. So everybody has to get the benefit of each one of these drugs by themselves or in combination throughout their lifetime. That is how we are prolonging the lives of patients. Clearly, the research, so as a part of that paper that we published earlier this year looking at the SEER database, we included patients from 1992 to 2007. And we used the 92 cutoff because before 92, Asians and Hispanics were not included in the database. So just to have a more equitable distribution, we said we'd only take the time period when all the ethnicities were equally represented. And we used 3 different cutoff points, 1992 to 1995, because 95 is when transplants got used a lot. 95 to 2003, because 2003 is when these drugs started getting FDA approved and getting more used.
Yeah,
and 2003 to 2007.
was 04.
Yeah. And then although the formal approval for REB, for example, happened in 2006, but the drug was available and used. So we compared 92 to 95, 95 to 2003, 2003 to 2007. And clearly, during these 3 groups, the more recent patients are living way longer than the previous ones because our drugs are making a difference. So I think the idea is that if a patient has a side effect, I have to be able to manage the side effect as long as my drug is working and keep the patient on that drug to keep getting the maximum benefit. So the philosophy, at least that I have, let's say, we were having this discussion last week in our county clinic, because in the county clinic, all our fellows, all our residents, all the attendings, we go down with county clinic for half a day. We see probably 70 or 80 patients in half a day, but then it's all the fellows, all the residents, all the attendings seeing patients sort of in town or in panel. So one of the fellows asked, he said, so now carfilzomib is approved, does that mean we should be switching our patients? I said, no, not at all. If my patient is responding to Velcade, hypothetically, if it's one drug that I'm using, which is very, very limited that I use one drug, why would I sacrifice that drug? Because I know that about 30% of patients who fail Velcade can respond to carfilzomib, but I don't know if the vice versa is true. And same is also true for the fact, let's say a patient is on a drug holiday right now. Okay? They were responding, a mutual decision was made between the patient and the doctor, let's stop treatment and let the body recover because the disease is very, very stable, nothing's changing, let's take a break. And let's say it took a break for 7-8 months. Now the disease is growing again. I think it's very reasonable to go back to the same drug. If that worked in the past, it may work again. Okay? We don't have anything to lose. We'll find out with another SPEP in 3 weeks or so, if the drugs work or not. So I think these things are very important to keep in mind.
Biphosphates, just as a follow-up to your statement about keep using the drug and not sacrifice that drug for something that's newer. What is your take on the use of Zometa past 2 years?
So last year, this large MRC9 trial came, which a lot of you might have also read, which was comparing Zometa to clodronate, which is an orally available drug available in Europe. We don't have it here. and the myeloma patients. And the philosophy that came out of the MRC9 trial, really large, really good study, was that the patients who got Zometa actually lived longer, everything else kept equal, suggesting that the Zometa may contribute to the myeloma control in addition to bone health. But that didn't really catch on so much in the US because I think, and even across the world I should say, because I think there are more nuances to that study and the idea that bisphosphonates should be used forever and ever. Right now, the safety data we have for bisphosphonates is for 2 years. And the reason that 2-year number is sticking in all minds are because the studies that were done before the FDA approval of Zometa were 2-year studies. Based on that, the drug got FDA approved. Once the drug gets FDA approved, we forget about looking at the side effects and we move on. I know the companies are collecting that data constantly, but we stop paying attention to that data unless and when something major or catastrophic happens and then drugs can be booked back. We know that our understanding of ONG or osteonecrosis of jaw has changed, and we know that the true number of that is somewhere between 5 to 10%. So, which means 5 to 10% of patients who go on Zometa can develop or have the risk of developing osteonecrosis of the jaw. So the way I use the bisphosphonates is, if my patient has bony disease or bony lesions from the myeloma, and they have active myeloma, as in myeloma that is substantially present, I will use the bisphosphonates for up to 2 years. And at that 2-year mark, I will reassess the need for the bisphosphonates. We have such effective regimens which work so fast at controlling the myeloma that if the underlying myeloma is in a good remission, let's say CR, then I will stop the bisphosphonate also. And I'll hold on to that for my future use. Because I think, at least as a community, we in the US have not universally taken on the idea that once you start with bisphosphonates, you keep going on it. Because I think there's some controversy that the bisphosphonates by themselves will alter the myeloma biology or not. They'll be protective on the bone, but the myeloma was causing bone issues. The myeloma is in remission. I don't have the driving force that is causing the bone issues.
Has it demonstrated that once you're on a glyphosate, that the bone involvement pretty much doesn't progress because it's being protected?
So the studies have happened not for bone disease, but what's called SREs, or skeleton-related events. That's what the studies focus on. So if we try to understand, the bony lesions are being driven by the myeloma. If the myeloma is in control, new lesions won't happen. But the breakage of bones at the site of a lesion is what the Zometa is going to prevent. So the Zometa will prevent those skeleton-related events. It by itself will not prevent new lesions from coming, because the new lesions are coming due to the myeloma. If the myeloma is progressing, new lesions can come. And that's why I said the controversy with the MRC9 trial, which is, like I said, a very, very large, very good study. But the myeloma therapy in that study at best used thalidomide. It didn't use Revlimid and Velcade. And so the idea is, in today's day and age when we have these drugs also have a benefit to the bones. So do we have to have the effect of Zometa to control myeloma, or the flip side is we can say that our Velcade or our Revlimid is helping the myeloma and also helping the bones, so we don't need to depend on Zometa that much.
But Zometa, like if you take a shot of the bone, it has, say, 2 lesions.
Yes.
You start the patient on Zometa. Has the data showed that patients that have been on 2 years of Zometa, 3, 4, 5 lesions?
That progression from 2 to 3, 4, 5 depends on what's happening on their underlying myeloma. So a study has not been done in which patients with 2 lesions, or for that matter, any number of lesions, were put on only Zometa and not any other myeloma therapy. Because the clean study which will demonstrate that would be patients who have bony lesions from myeloma, half of them get Zometa, half of them get nothing. And then we see how their disease progresses. That would be an unethical study to do. because we'll have to treat the myeloma with anti-myeloma drugs. So I think, I know it's a little bit of a complicated discussion, but I think what I'm trying to get at is that the development of new bony lesions is a product of the underlying myeloma. And Zometa itself cannot control the underlying myeloma, so the Zometa will not prevent new bony lesions. What the Zometa will do is it will prevent the complications from existing bony lesions. Does that make sense? That Zometa will prevent the bone breakage or osteoporosis, which we know Zometa will help. Because we know that as a class.
Won't Ailawadhi do that too?
Exactly. So Zometa and Ailawadhi. And I'm using them kind of interchangeably because right now the reason we end up talking more about Zometa is because it's a faster drug. It can be given over 30 minutes, as against Ailawadhi, which will go over an hour and a half. Ailawadhi is safer for kidney function. Zometa has to be safer for kidney function. Ailawadhi you can give irrespective of kidney function. And the body of literature is different for Zometa and Ailawadhi. We think it's interchangeable. But we also know that the osteonecrosis issue is more so with Zometa, at least reported more so with Zometa than with Ailawadhi.
What's the typical maintenance dose after transplant? Is there a typical one, or does it depend on disease progression?
Thanks, very excellent question. So about 3 or 4 months ago, 3 very large international studies have been published that are addressing the maintenance question. One of them is in the non-transplant setting, 2 of them are in the transplant setting. Without going too much in details about the literature, I'll tell you what I'm doing. And I also know, for example, the City of Hope is doing the same, or at least Dr. Krishnan, who's their chief at City of Hope. We keep talking about different studies within certain same clinical trial groups, for example. The general guideline that I follow is that it's not that everybody who gets transplant should go on maintenance, because there is emerging data that maintenance is making patients live longer, but not so much convincing so far. Some updates will be presented this year. So what we're doing is, if a patient has gone into a complete, has had a complete response prior to the transplant, and they maintain their complete response after the transplant, I won't give them maintenance. If a patient is not in a CR, I will give them maintenance. If a patient is in a CR but had high risk cytogenetic features in the beginning, then I will give them maintenance. Okay? So 3 categories: no cytogenetic problems, CR, no maintenance. Cytogenetic problems, CR, yes, maintenance. Not ACR, maintenance. So these are the 3 groups that the way I'm following it and the way I'm doing it right now. We'll have some updates this year in December. And generally, that post-transplant, what's being studied is Revlimid, a lower dose of Revlimid, 10 milligrams, as against the full 25 milligrams.
Is it a typical cycle of 3 days on, 3 days off?
And that's the dose that has been studied mostly with trials. Because if you're using a full dose Revlimid with Dex, then that's not a maintenance, that's the full dose treatment. Right?
Yeah. And when it starts affecting your white blood count, will you change it?
Absolutely. Every time that a drug is had, because think of it this way, the decrease in white cell count or platelets is a drug side effect. So if I'm saying that a drug side effect has to be managed to continue with the benefit of that drug, that holds true for Velcade neuropathy, that holds true for constipation from thalidomide, holds true for neuropathy from thalidomide, holds true for clots for thalidomide and Rev, and also holds true for decreased counts from Rev. Because if I treat my patient with a drug to the point that a side effect becomes prohibitive, I've lost that drug effect. I have to manage the side effects, which could be dose adjustment, schedule control, whatever I do, to continue on that drug for longer. That's where the use of subcutaneous Velcade comes. Because if the neuropathy is lesser, I can keep my patient on treatment longer and give them that benefit. I don't want to sacrifice a drug that is working. Or I don't know what Yes.
He'll go down and talk to you individually if you so have some questions. And just before we officially adjourn, I just want to make some more announcements. Okay, next month we will have, it's on your list, I believe her name is Pearl Fang, I can't get her last hyphenated name. She is the medical liaison for Onyx. She will be here to give an overview about the recently approved Kyprolis. So you don't want to miss that.